co-pays and deductibles. That's what we would want in a single-payer approach. But you get some major savings. Some of those are at the administrative costs of health insurance companies. But as I mentioned earlier, there's also going to be some savings in my office because I won't have to hire that extra person that deals with all the bills, and there will be savings in hospitals. We did a comparison between Toronto General and a similarly sized American hospital. 3 billers at Toronto General, 300 billers in the United States. You know, that's the kind of thing that one could get real savings from, so that in fact what you would see is something like this. The number of doctors that have increased since 1970 is this yellow bar. But look at the number of administrators. And that goes with when managed care or HMOs really started, early 1990s. We need to amputate that group. Give them meaningful work instead of pushing papers, denying claims. What we need is a jobs retraining program, and HR 676, although it doesn't detail it, calls for a jobs retraining program, because there would be some major disruption, frankly, if we went to single payer, because we wouldn't need these folks doing all the kind of meaningless work that they presently do. Yes?
Would that, the single payer, would that eliminate the Medicaid?
In my mind, we would not need Medicaid under a single payer program. Everyone would have the same health insurance. People with low income might need certain subsidies to utilize care, you know, like transportation subsidy, what have you. But by and large, we could eliminate Medicaid, which would be, I think, a very positive development, now that we don't have 2 or 3 or 4 classes of care, essentially. Yes?
The people that are on Medicare now, if the system were adopted, and if there were progressive tax, we would then be paying a percentage of our income as well and become part of the whole single payer program.
That needs to be worked out, okay? That is one of the very interesting dimensions of things, because you have already paid into the Medicare program. All of you have, through your lifetime. And it would seem to me that what we would work out in a single payer program is a way, in fact, in which people over 65 who have paid in would not necessarily have to continue to pay in. That is a detail that is important.
Because if we're not covered for long-term care, for certain catastrophic care, for dental care, so there's certain coverage that even though we paid for, we don't have now.
Yeah.
But we're still paying. We still pay Medicare premium, and
Well,
we still pay
yeah,
for secondary coverage.
That's one of the other dimensions.
That's right.
Medicare, we hope, would be improved so that the Part B side of Medicare, which is where you're paying premium, right,
And the secondary coverage, the Medicare.
and the Medigap coverage would in fact be dealt with in terms of a healthcare reform. So that's, you know, those are very interesting dimensions of how one would get to a good single-payer program. And I just want to show you these overhead and administrative costs are not made up by me. This is Carl Schramm, a conservative economist, and you can tell he's conservative, right? Because when he looks at the overhead of a commercial insurer, he says it's 19.9%, not 20%. Right? I couldn't believe this, but that was there, right? And you can see what happens when you convert from a non-profit blue to a for-profit blue. Your overhead goes from 16 up to 26%, and that Medicare, he agrees, has this low administrative cost. The fifth principle is maximum choice of provider. Very important principle that there's free choice of doctor and hospital, not just the choice of a health plan. This is, a program that gives consumers really purchasing power in the system. This is real consumer-directed health care. All of this should be delivered through a tier-free healthcare system. I would eliminate copays and deductibles. These are very crude ways of trying to constrict the demand for services, right? Using a financial incentive to do that. And what we've shown over and over again is that you eliminate, or you retard services that are needed equal to the number of services that are frivolous or unneeded. Let's get rid of that. If we need to control demand in healthcare, we need much more creative ways to do it. No need for Medicaid, as we spoke earlier. Very controversial, probably the most controversial thing I'd say is that I personally advocate no private insurance that duplicates the public coverage. And it's usually at this point in the talk that people say, oh my God, Dr. Fein has just jumped off the edge of the world. What country would not allow a private health insurance entity to cover something? Is there such a country?
Would there be a limit on expenditures for your health insurance, for your health? Say you need something extra,
There should be no cap. Absolutely not.
you can spend whatever they need for the operations and everything?
Yeah, it should be that way. Absolutely. Is there any country?
Cuba?
Cuba, no. Cuba, it may be true, but that isn't the major country I'm thinking of. It's Canada. Canada has this law. Now, it's been challenged, interestingly, in the province of Quebec, but you got the idea. Quebec can sometimes be a little crazy place. And the Supreme Court of Quebec has, in fact, ruled that this might be changed. But that's not true for the rest of Canada right now. And, you realize, frankly, that the Medicare program, when it was passed, said you can't buy supplemental coverage from a private insurance company to cover the basic things that are covered in the Medicare program. I don't know if you realize that, but that's the case. The supplemental has to be literally for things that are supplemental. So it's possible to think of doing this in the United States, albeit that this is a little bit more radical. And why do I not want private insurance duplicating the public coverage? Because the private insurance industry will recruit the young and the healthy and exclude the old and the sick. And they do it in the most subtle ways. We have the experience of Medicare and Medicare Advantage. Have you ever seen those policies where they say, we'll give you a free health club membership?
Yes.
Oh yeah, Oxford is out there always doing this. And I said, this is great. I want my patients to exercise more. I want them to go to the health club. And then I thought about Mrs. Smith, with her crippling arthritis. Or Mr. Jones with his angina and shortness of breath. Are either of them going to be interested in a free health club membership? No way. The insurance company is recruiting the healthy and leaving the sick in the traditional Medicare